Hi everyone, and very good evening to all of you. Guys, please confirm if I'm audible and visible. In case everything is fine, we'll start the session. Just to introduce about the session, it's just a PYQ based session in which talk about all the questions that's come from right from 2023 onwards, 2020 onwards. I'll just try to include the NEET PG 2020, 21, 22, and 23 questions. And just because of the interest of the time, and I know that time is very crucial for all of us in the time remaining, I will try to limit the whole session in just 1 hour. Okay. I'll try to tell you all about the question that can come from this topics as well as the corresponding topics here and across that. So first of all, I just need to know if my audible and visible. Uh, Sure, it's audible and visible. Guys, because this session is all about not creating a FOMO. It's just to have this friendly talk to each other. We will try to include all the questions that can come from these topics as well as the questions that can come in and around it. Okay. I'll not write a lot of things. I'll just try to speak to you a lot of things. Just try to listen to me very carefully as we move ahead into the sessions here. Okay. So I hope that you all are ready and we can start the session. A thumbs up from all of you, whoever has just joined this link right now. So guys, let's start the session. Perfect. Okay, great. So as you know the answer, just try to click on the whatever answer you know. The first question is identify the histological image as shown in this image. When this question came, a lot of students confused between the option number A and option number B. Okay, there was a confusion there. So when a question like this comes across, what you should look into, this is not actually, the question actually was between a glomeruli and islet cells. Now this question here is not the islet cell, okay? This is actually a glomeruli. And what you can see across this area, these all are glomerulus. And these are all the tubules across this area. So this actually is a glomeruli, okay? This is all the glomeruli. And the area around them are the tubules, okay? Let me tell you, if this would have been a pancreas, would have shown you islet cells, and the islet cells should not have been this type of area. It should have been a cross round the type of glands, which are the exocrine portion, and between them there will be cells like this. That would be the islet cells of the pancreas. So if you see a gland, along with that, if you are seeing this small color cells into it, that would become pancreas. But this actually is a glomeruli. Also understand that if you see a Leydig cell or a Leydig cells, these would see in testis. So testis will have this type of seminiferous tubules like this, assay. And from this, the spermatozoa would actually come out. This actually is a seminiferous tubules. And suppose I'm getting one more seminiferous tubules. Suppose this one more seminiferous tubules. Then what I'll get as cells between them would be Leydig cells. Okay, assay. So this would be basically Sertoli cells in a testis, and these would be the Leydig cells. About the parafollicular cells and the follicular cells, the follicular cells and parafollicular cells, these are seen in which organ? It is seen in the, yes, actually it is seen in the case of thyroid gland. Okay, it is seen in the case of thyroid gland. Just remember, the parafollicular C cells would basically be making, parafollicular C cells, they would be making the calcitonin, and the thyroid follicular cells will make the T3 and T4 when they combine with the TG of the colloids along with the iodine from the vessels. Okay. A 45-year-old patient who is a chronic alcoholic presents with abdominal pain. Lab studies reveals an alkaline phosphatase level of 230, looks quite to be high, and a conjugated bilirubin level of 1 milligram per dl. In addition, this alpha beta protein is found to be significantly elevated. What is the most likely cause of the diagnosis? See, this case may, what you're seeing is the AFP level is very, very high. Okay. The AFP level is very, very high. Since the AFP level is very high here, it going towards a case of hepatocellular carcinoma. So what they can ask you here is, first of all, what would you see in hepatic adenoma? In adenoma, you'll see either a OCP history, or you can get a history of anabolic corticosteroid. That's one history you'll get. About the alcoholic hepatitis, they can ask you about the AST is to ALT ratio, which around is 2 to 3 is to 1, 2 to 3 is to 1. And in a focal nodular hyperplasia, Often, there are two types of hyperplasia. One is a focal hyperplasia and one is a nodular regenerative hyperplasia. The two types of hyperplasia which can be seen in the liver, and both of them are not exactly tumor-like conditions. A tumor-like condition, not a tumorous condition, is neither a benign tumor nor a malignant tumor. It is a hyperplasia. It can be a single nodule. It is called as FNH, or can be multiple nodules called as NRH. Okay, single nodule is FNH and multiple nodules called as NRH. This is the case of HCC because you can see the AFP is sized. They can also ask you what are the other markers for HCC apart from alpha beta protein. The other marker for HCC are PIVKA and des-carboxyprothrombin Okay. Yes, the AFP can also be increased. That's a very important question. The alpha beta protein, apart from the HCC, it can also be increased in a case of a yolk sac tumor. And how to remember this? The alpha fetus of an egg the fetus of an egg is actually derived from the yolk, right? The yolk becomes fetus. That is how you should remember. A yolk sac tumor would make the alpha fetoproteins. Okay, this question is a 25-year-old male presenting with low hemoglobin and the platelet count is around 25,000. Okay. The history of gum bleeding is there with raised PT and ABDT. So when you get a question like this one, this points towards already the patient has gone to DIC. So now you should think into which of the tumor cells can lead to DIC. And what you see in this image are plenty of OR rods. These all are OR rods you see here. Okay, these all are OR rods. So when you get this type of multiple OR rods, it points towards a AML M3. And AML M3 shows what mutation? It is translocation of 15 and 17. In this point, I would just suggest you to go through the three types of AML. Is M2, M3 and M4. Okay. Among these three, what you should know is the M2 often shows 8-21 translocation, M3 shows 15-17 translocation, and M4 often shows a 16 with 16, also called as inversion of 16. Now, what is striking is in the new classification of WHO, they have just tried to decrease the usage of the numbers and they switched over more to telling the names of these. Okay, just example, you all know 15-17 is very importantly called as PML with RARA. Okay, it is called as PML with RARA. Now remember that it is RUNX, 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 and RUNX T1. That's a 821, yes, and it is the MYH with CBFB, which is the 16 with 16. So what you should know about these three is in the recent WHO 23 classification, they have told that if you get any of the three mutations, it is actually AML, and that is irrespective of the blast count. These all are AML irrespective of the percentage blast. Okay, got the point? That's a very important thing that has been changed in the WHO classification 2023. That's what you should know. About the other mutation, just remember the NPM mutation hai, SEPA mutation hai, FLT3 mutation hai. I'll just add one more information here that FLT3 mutation in the case of AML has a poor prognosis. Just try to remember this thing, that's it. What they have asked in a few 2 years back in also INCT is what is the treatment of choice for a PML RARA gene? This was asked question, and this was actually all trans retinoic acid, ATRA. So ASO3, arsenic trioxide with ARTRA are the two drugs which can be given in a case of PML RARA mutation. PML RARA mutation. Okay. I'll just move to the next question now. Okay, this was a bit, this was a bit controversial question, I'll say. I will just make it very clear what is it asked about. A patient with creatinine 4.5 was positive for HBS antigen and HBE antigen. There was a spike and dome pattern on the kidney biopsy. Spike and dome pattern on the kidney biopsy. So when you get a history of HBS antigen, it points toward HBV infection, right? And now you get a spike and dome pattern, it becomes clearly a case of membranous nephropathy. So what I would suggest is, at this point of time, you can't remember everything. So what I'll tell you is just try to remember in the minimal change disease, you'll get a history of LMA, no finding. FMA, you will not get no finding. The only finding in the electron microscopy you'll get is a podocytopathy. And guess what is podocytopathy? It basically means the effacement of food process of podocytes. In membranous, you'll get a diffuse GBM thickening, and along with a diffuse GBM thickening, what you get is a spike and dome pattern. Okay, spike and dome pattern. In FSCS, what you get again, you get this condition on the electron microscopy, that's podocytopathy. But more importantly than the podocytopathy, okay, more importantly, look at the name FSCS. So it must show you what? Sclerosis. It shows fibrosis. fibrosis in the glomerulus. Fibrosis in the glomerulus can be seen in the FSGS. Okay. PSGN what you get is a hump, and this hump is a finding in the electron microscopy is what you can get in that part. Just remember one thing, they can ask you that when you talk about a case of infections, so HBV will often show a case of MGN, HCV will often show a case of MPGN, and HIV will often show a case of FSGS. Just remember they have also asked you about leprosy. So leprosy can show you both MGN and MPGN. I would suggest you go with this case as more commonly seen in a case of that. Kala-azar has been asked, and Kala-azar often shows a case of MPGN. Okay, FSGS is mainly seen in HIV infection. HIV infection. So any of the doubts you may please keep on asking me. As I get time, I'll surely ask you there. Ask you there. Just remember, guys, if you get a question on a porocytopathy, this case, it can be seen in not only MCD, but apart from there, it can be seen in MGN and when can be seen also in the FSGS like finding. Clear है? It's okay. ठीक चल रहा है सब कुछ? All of you okay? चलो. This was also a NEET PG 23 question. So this question pointed towards a 4-year-old child brought with an episode of icterus and pallor. Child presents with intermittent jaundice as splenomegaly and a history of similar complaints in the elder brother. Peripheral smear finding shows this one. What are these? These are all spherocytes, right? They're spherocytes. So in the question, what you get striking is two things. Okay, child hai, episode of icterus and pallor hai, and there is intermittent jaundice as splenomegaly hai. Very importantly, they have a similar history. It means it is something linked to the pattern of inheritance. So because it is a similar history in the elder brother hai, you cannot answer here autoimmune hemolytic anemias. Because in the absence of drugs, drug का कोई history नहीं है. There is no history of any infections. There is no history of any fava beans, and therefore you should not go into the case also for G6PD deficiency. If this would have been a PNH, would have given a typical history that there is an increased hemolysis that would occur at night. This would have been a typical case and would have shown you CD55 or 59 deficiency or absence. This is a typical case of HS, which shows OFT, and what they can ask you in the OFT is the OFT curve. It shifts to what side? OFT curve shift to left side or right side? Can you all tell me what side? Which side, guys? Left side or right side? Yes, the curve shifts to right side. And when I say it's right side, it means what? It means increased OFT. Perfectly answered. Okay, it means increased OFT. Chalo, next question. An African child was found to have a mass in the jaw. Okay, a biopsy of the mass was done and appears as shown in the image below. The child also has a translocation of 814. Now this was a case, it was actually made easy because they have given you 814 translocation. The moment you see a 814 translocation, guys, the answer has to become a Burkitt lymphoma. So what you see in this case, this is not actually a starry sky appearance. वो नहीं है. So these are what? These are the vacuoles, the cytoplasmic vacuoles. Cytoplasmic vacuoles in the cell, and these often mimic a cell called as ALL-L3 pattern. It often mimics a cell pattern called as ALL-L3 pattern, right? So when you get a ALL-L3 pattern, it points towards a case of Burkitt's lymphoma. Clear? Burkitt's lymphoma. So in which case, in 5, question number 5 mein, why it is not B? Because it is not B because this is a hereditary history. It's a family history. And whenever you get a case of autoimmune hemolytic anemia, in this case, you'll get a history of drugs, or you'll get a history of infections, or you'll get a history of any autoimmune disease like SLE, RA, वैसा history होना चाहिए, and hence it is not B also. I think I made it clear. So how does Kala-azar called MPGN? Is all about the infections and the antigen antibody reaction which can lead to MPGN in case of Kala-azar. Like same also goes for HBV and HCV also. They all are antigen antibody reaction which can deposit in the glomerulus and can cause this type of episodes. Okay? This is a case of Burkitt lymphoma, and they can ask you about the infection. They show Epstein-Barr virus positivity, number 1, and very importantly, what they also show in Burkitt lymphoma. Apart from this, what they also show in Burkitt lymphoma is a starry sky pattern. ठीक है, do not forget this is actually c-MYC positivity, and c-MYC because of chromosome number 8 it shows 8, 14, 28 and 8, 22 also. I just remind you guys that in the follicular lymphoma it shows BCL2 positivity, and in multiple myeloma it shows multiple translocation including chromosome 13 q deletion, 14 के साथ 4, 14, 14, 16, 14, 20, all the 14 वाला will be there in multiple myeloma. ठीक है, चलो a lung cancer with large atypical cells, बताओ. Large atypical cells are there, but there is high serum calcium. Large atypical cell with a serum calcium, what it should be? The moment you say high serum calcium, let me tell you, it cannot be any neuroendocrine tumor, because neuroendocrine tumor it releases what? Calcitonin, which should ultimately cause hypocalcemia, not hypercalcemia. Okay, there's a very interesting story, because it is showing you a large size atypical cells. Many of the students would be tending to mark it like a large cell cancer, but ऐसा नहीं होता. Because it's showing you hypercalcemia, what you should mark is, yes, squamous cell carcinoma. Let me clearly tell you some of the questions that can be asked from a lung cancer. Listen to me very carefully, guys. देखो, most common lung cancer in India worldwide is adenocarcinoma. ठीक है, most common lung cancer in smoker is squamous cell cancer. Small cell cancer is seen only in smokers. Most common lung cancer in non-smoker, in young age, female, India, world is adenocarcinoma. Most common lung cancer with almost every paraneoplastic syndrome is seen with small cell cancer, except hypercalcemia, which is seen in squamous cell carcinoma. Squamous cell cancer shows 2C, cavitations and hypercalcemia. About the histology, they can ask you. Squamous cell cancer will show you keratin pearls. Adenocarcinoma will show you glands with mucin. इतना पढ़ लो. And one more thing, azoparty effect is seen in small cell cancer. बस इतना पढ़ लो बस. ठीक है, चलो let's move to next one. A biopsy in a patient of rectal mass of 2.5 to 3 centimeter shows a chronic mucosa with a mucin filled tissue. क्या है ये? Mucin filled tissue. This is a case of hematoma. Now देखो, this is a incomplete question actually, I'll tell you. But actually the question should have been age wise. The moment you see an age of less than 5 years, it becomes, in this case with a mucin filled tissue, it becomes a case of, yes, juvenile polyp. Juvenile polyp. In the same case, suppose it has women, suppose a peri-oral hyperpigmentation would have become a Peyer's polyp. Just remember, both these polyps, juvenile polyp and a Peyer's polyp, both of these polyp are, yes, hamartomatous polyp. I just remind you guys that in case of a benign polyp, it is three types. It is HHI. It is called as hamartomatous, hyperplastic, inflammatory. Okay, these are all benign polyps. Malignant polyp is adenomatous polyp, which includes a very typical mutation called as APC gene on chromosome 5q. It makes a syndrome called as FAP. But do remember, guys, that adenomatous polyp is a malignant polyp by nature. उसे benign polyp नहीं होता. Adenomatous polyp is of three types. One is a tubular polyp, one is a villus polyp, and one is a combination tubular-villus polyp. Who is the villain? Villus is the villain. So villus is most invasive. Okay, this is what you must remember. Yes, small cell cancer and the old cell cancer is same. About the microscopy of a Peyer's polyp, it shows the typical arborizing pattern. Correct. It shows typical arborizing pattern. Okay. Okay. Now this is a question which was a bit confusion there. The page question was, there was a hematuria and a past history of prodroma with upper respiratory tract infection. The moment you see this one with a case of hematuria, do you think about PSN? I don't think there's any doubt there. It's typical case of PSN. What is the question giving you? Initially creatinine level was 2.2 and now has increased to 4.5. क्या हो गया इसको? Is a sudden onset of acute renal failure. ठीक है? What is expected on the electron microscopy? Patient में PSGN है and asking you the EM finding. I completely agree. This is a case of RPGN. Okay? Had the question been about the light microscopy, please समझो बात को. Had the question be a light microscopy, I would have marked this as an answer. कोई doubt नहीं इसमें. However, the question is electron microscopy finding. I cannot see present as a finding, and therefore for a PSN, my answer should be subepithelial deposits. Did you get the point? Also remember subendothelial deposition. This is a case seen in a case of MPGN type 1. Okay, MPGN type 1. It can be seen in SLE, guys, SLE, and it can be seen in some miscellaneous causes, but not very important. The epithelial deposition can be seen in PSGN, it can be seen in MGN, and can be seen in a RPGN type 2. Okay, present is seen only in a case of RPGN, but it's a light microscopy finding. Mesangial deposition is seen in a case of IgA nephropathy. So what is left out, guys? The only finding that you can just add up there, subendothelial ho gaya, subepithelial ho gaya. There's also mesangial deposition. It can be a membranous deposits. If the question is on membranous deposition, the answer should be MPGN type 2. Bus. Yes, suddenly creating this one, and hence the answer is RPGN. कोई doubt नहीं है. It is RPGN. However, question में light microscopy नहीं पूछा है. Is asking about the electron microscopy finding, and so the answer here is actually what? It's a case of PSN going to RPGN, EM finding is asked, and hence the answer is B. Okay? Chalo. Now look at this question. Now this is a pretty tricky question. It's all image based though. A 55-year-old male presents with fever and fatigueness and left ventricular dysfunction. Now you see this is a cardiac environment given, and all the cells you see here, these actually are what, guys? They're lymphocytes. Because these all are lymphocytes, you have to choose a case which is lymphocytic myocarditis. ये lymphocytes हैं, and these are the myocardium. And hence it's a case of lymphocytic myocarditis. ठीक है? Chagas disease doesn't show these type of finding at all. Chagas disease mainly is about the destruction of the ganglion. Okay, in this disease, there's a ganglionic destruction in the GIT. Pyogenic may you see neutrophil infiltration. Acute rheumatic fever may what to get is a ash of bodies, and all the ash of body will contain a typical type of cell called as anastomoses. Okay, chalo. 11. 45-year-old cement industry worker for a 20-year-old develops mesothelioma. Okay, so mesothelioma is a short association with what one? It is seen with asbestosis. Just remember, in asbestosis, a more common lung cancer actually is not mesothelioma. Actually, it is adenocarcinoma lung, which is much more common than malignant mesothelioma. Okay, silicosis rarely causes this type of finding. Silicosis mein what are all are important? It shows the eggshell calcification on the X-ray. It shows the crazy pavement appearance on the CT imaging. It shows bilateral hilar lymph node enlargement. Okay. Bagasosis basically is a hypersensitivity pneumonitis. Okay, pneumonitis. Anthracosis is basically a coal worker pneumoconiosis, which shows the coal macules and the coal nodules. Yet more specific can be mesothelioma, but more common in the asbestosis is actually adenocarcinoma lung. Okay. Cement industry enough nahi hai, but yes, it is almost because mesothelioma dikh gaya na, and hence it has to be asbestosis. Cement industry is not enough to say this as asbestosis. Okay. Yeah, sugarcane se hota hai the bagasosis. Kaplan syndrome can be seen in all the three types of pneumoconiosis. Remember, Kaplan syndrome was first seen in anthracosis. Kaplan syndrome was first seen in anthracosis. Silicosis increases risk of TB. About the asbestosis body, just remember, asbestos body hote hain, ek fibrinous body hote hain. If there is a coating of iron and protein, and inside them there is an asbestos particle, it is called as asbestos body. If there is any other type of inorganic particle, it is called as ferruginous body. Just to tell you guys, more specific among these two is asbestos body. Okay? Chalo, question 12 dekhte hain. A chronic alcoholic presented with abdominal pain and jaundice. AFB is raised, AST, ALT is normal. So AFB is very high in this case. Kya ban gaya? Alcoholic person hai, it has to be a case of the um, hepatocellular carcinoma. Okay, hepatocellular carcinoma. However, that is not in the option. So in this case, we have to choose only cholangiocarcinoma. There is no other way. We have to choose cholangiocarcinoma in this case. Acha, lobes ke bare, in this case, I'll just choose cholangiocarcinoma because HCC is not in the option, but I would have chosen HCC as the better answer here. Just coming up here, lobe mein, dekho, the only one which involves the lower lobe is the asbestosis. All the other two involves the upper lobe. Okay. Chlorotic sinuses cause which cancer? It's a straight of a case of cholangiocarcinomas. Among them, देखो bladder cancer तो नहीं होता, but bladder lymphoma, it is caused by Helicobacter pylori, and which lymphoma? It is called as maltoma. Okay, schistosomiasis, it causes bladder carcinoma, and human papillovirus, it causes cervical carcinoma. In HIV, the 16th strain is more dangerous than the 18th strain. Okay, okay. Now, this is a tricky one. All of you listen to me very carefully. The following is true regarding the Mendel mode of intense true पूछ रहा है. Okay. Just remember, in the Mendel's law, in 66% of all the disorders is hormone dominant. AR comprises of 25%. X-linked. Okay, just remember, X-linked, which comprises of X-linked dominant plus X-linked recessive, is around 5%. Here हुआ. And one more. What is remaining? कितना ऐड करो ना, मान लो कि 65 मान लो इसको, जस्ट कंसीडर दिस टू बी 65%. ओके, 65% कितना हुआ? 75, 85, 90, 95. तो व्हाट अदर्स? नॉन माइटोकॉन्ड्रियल आर 5%. नॉन माइटोकॉन्ड्रियल 5%. इट मींस इट इज व्हाट? दिस इज द राइट स्टेटमेंट. ये ट्रू है. देखो, एक्स-लिंक्ड डिसीज कितना हो गया? दिस एक्स-लिंक्ड, पूरा एक्स-लिंक्ड मिला के 5% होता है. ओके, सो हियर द आंसर, राइट आंसर इज डी. राइट आंसर इज डी हियर. Clear hai? This is a person you should all notice here. Chalo, next one. Okay, what is this patient suffering from? There's a hyperthyroidism. It looks to be a Graves' disease, and a patient has a neck swelling with the finding of exophthalmos, and he has tachycardia, tremor, and sweating. So most common antibody in a case of Graves' disease is what? Graves में the most common antibody, thyroid stimulating antibody. However, just remember, अगर C is not in the option, you can also go with B. In fact, अगर B is not in the option, you can also go with A. So Graves' disease में all of these can be seen. The most common antibody in Graves is thyroid stimulating immunoglobulins. ठीक है? अच्छा. TPO antibody especially is seen where? It is seen in a Hashimoto thyroiditis. Hashimoto thyroiditis. Here the best answer is C. If C would have not been the option, I would have taken B. If B would not in the option, I would have taken A. ठीक है? चलो. Elderly male or routine examination was found to have a marked elevation of lymphocytes with marked leukocytosis. Peripheral smear is shown below. What is this? It is showing you smudge cells, right? ये क्या है? Smudge cells. And hence it is CLL. Because the tumor cells are already in the blood. समझो बात. Tumor cells in the blood. So why to take someone's bone marrow? Why to take someone's lymph node? If you're seeing the sample in the blood, tumors in the blood, send this blood sample for CD marker diagnosis. It'll come as 19 positive, 20 positive, 23 positive, 5 positive, along with 45 positive surely. To look for the CD marker in the blood sample, what test to do, guys? You must do flow cytometry. Okay? Had this been a case of suppose I would say AML or ALL, I would have gone with bone marrow biopsy. अगर bone marrow biopsy have been given more than 20%, I would have gone with flow cytometry. तो देखो क्या होता है, in acute leukemia you must first prove 20% count, and therefore after blood smear you must go with bone marrow. But अगर it is given more than 20% already, then go with flow cytometry. In CLL CML you don't need to prove 20% blast. Hence, you straight away go with, in CLL case, the flow cytometry. In CML, you can send the sample of blood, or in bone marrow, whatever you get for the fish analysis. Okay? Sure. A young patient presents with large peritoneal hemorrhages and frequent history of intermittent swelling on the knees and as well exercises. It points towards which history? Yes, a hemophilia history. There's no history of mucosal bleeding, and therefore you cannot mark the answer VWF. Factor 12 में there's no bleeding. There's no bleeding in factor 12 patients. You must only answer lac or APLA only if you get a history of a pregnancy. Only if you get a history of pregnancy, and that case presenting with history of thrombosis. Then only you must mark APLA or lac. Here the answer is factor 8 or factor 9. It points towards a hemophilia. Remember, hemophilia में मिलेगा आपको दो history. One is a joint swelling and hematolosis, and was a muscle bleeding called as a muscle hematoma. ठीक है? Also remember, for a factor 8 deficiency, we should give the cryoprecipitate and the FFP. For a factor 9 deficiency, we must give only fresh frozen plasma. We cannot give the cryoprecipitate. We can just surely give a cryo poor plasma, but we should not give the fresh frozen, cryoprecipitate, because the cryoprecipitate has factor 8, VWF, and also fibrinogen. Okay? Chalo. This completes our question of NEET PG 23. I'll now move to NEET PG 22 questions. All of you ready, guys? How many of you are still there? Just give me a quick all of you thumbs up, and let me know how are you. Are you okay with this type of quick revision? I have half an hour more, and I have to cover around 60 questions, and I'm sure I can do this. It's a challenge for me also. बढ़े आगे. Do share this video फटाफट to your friends also. They can also come up, and there's a like button. वहां पर like मारो and see it will give you a love also to you. अभी मैं आप लोगों के लिए love मारता हूँ. So चलो. NEET PG 22 questions. First question. A patient of ARL shows lymphoblast in a smear and in a pain abdomen. Lymphoblast and this decreased urine output. Workup shows increased potassium and increased uric acid. This whole story of increased potassium and increased uric acid points towards a tumor lysis syndrome. In tumor lysis syndrome, they give you a history of hyperkalemia, hyperphosphatemia, hyperuricemia, but hypocalcemia. The first therapy you should give is hydration. First therapy. If not in the choice, second thing you can do is probenecid. Okay, you can also use allopurinol. You can also use xanthine oxidase inhibitor like the febuxostat. If nothing is working later on, what you can give ultimately dialysis therapy. And just remember, when you give hydration, the forced alkaline diet is not required. A typical case of normal saline can be given, as mentioned in Harrison's, that a typical IV hydration is sufficient. You don't need to give the bicarbonate as you do in the treatment of the hyperuricemia. ठीक है? देखो क्रायो किस कंडीशन में देना है, बहुत सिंपल है. Actually you must just know कि क्रायो has what? A cryoprecipitate has factor 8, VWF, and fibrin. Once you know this, there is no confusion. Hemophilia A, von Willebrand disease, and hypofibrinogenemia. Question number 2. A 4-year-old was brought to the hospital with complaints of frequent falls when he tries to get up. He was also found to have difficulty in getting up from squatting. This type of problem in a 4-year-old child points towards a Duchenne's muscular dystrophy, which is an X-linked recessive disorder. Okay, this whole thing is a atrophy of the muscle. This whole thing here, it's a muscular atrophy, and hence it is Duchenne's muscular dystrophy, DMD. Duchenne's muscular dystrophy is the diagnosis here. Now, just remember, Duchenne muscular dystrophy, it's not a post-viral pathology. It is due to the dystrophin gene mutation. Myocarditis is not the problem. It's basically the X-linked disease on which the dystrophin gene is there. Death occurs in third decade. Yes, that's a true statement here. That's a true statement there. And action prognosis, if dated early, is not the right statement. So that's what you must remember. Death occurs in third decade, and most common cause of death in DMD is respiratory failure, more common than the cardiomyopathy. Most common क्या है? Respiratory failure is the more common cause of death in case of Duchenne's muscular dystrophy. ठीक है? चलो. 3. A child, middle-aged lady died of COVID-19. She was on ventilator. The following finding is seen on lung autopsy. lung autopsy. बताओ. So this is the case of, yes, ARDS. Because the case of ARDS, you will actually find a thick fibrin lining the alveoli, and what is this called? Hyalin. Okay. Intracellular and nuclear bodies, as they can be seen in the infective conditions. Acute and chronic hemorrhage in the lung tissue. It is seen mostly in the pulmonary hemorrhage conditions, in hypertensive pulmonary hypertension and all. Edema is a non-specific finding, and therefore not the answer. Okay, that's not therefore not the answer. Here the answer is clearly A. It's a hyalin. What they can ask you here is, it shows hyalin membrane disease with a diffuse alveolar damage. The most common injury to the cell which happens here is a endothelial cell, more important than the type 1 pneumocystis. Also you must remember guys, the type 2 pneumocystis intact in a case of ARDS. Clear हो गया? चलो आगे बढ़ते हैं. A patient who has a fatigueness and a microcytic hypochromic anemia with a reduced RBC indices, है ना, मतलब ये क्या कह रहा है, MCV is low कह रहा है, and target cell is there. Target cell कहाँ दिखता है? In iron deficiency anemia and a case of thalassemia. Now hemoglobin is looking as a reduced, MCV is 60, MCH is 23, MCH is 27, RBC count is 5.2. अच्छा, Menzel index देना नहीं चाहिए था. Menzel index is given, but it should not have been given. Actually, you'll see, देखो, when you get a case of iron deficiency anemia and a case of thalassemia trait, both of them have a MC which is low. Then you must look at the RBC count. अगर RBC count is low, the Menzel index, which is a MCV upon RBC count, it is almost like a bit higher, is more than 13. However, since thalassemia trait में the RBC count is normal, is less than 13. So here it is basically less than 13 and 10 दिया हुआ है, and hence it points toward thalassemia trait. So what you must do is HbA2. HbA2 level should be increased in the case of thalassemia trait, and hence the answer is A here. When you would have done ferritin, in this case you would have done ferritin levels. Folate, if the MC would have been high, and also same with homocysteine, because even homocystinuria and hyperhomocystinemia can sometimes lead to hypohomocystinemia can also lead to the B12 deficiencies. ठीक है? चलो. A 56-year-old male came as a dragging sensation in the abdomen, and there was a massive splenomegaly. Lab investigation reveals very high TLC, and there's myelocytes, metamyelocytes, promyelocytes, and band forms of neutrophil C. 56-year-old patient है, dragging sensation. This typical word is used for CML first of all. And when you see these all cells, we call them a garden party appearance with a left shift. When you get this type of history, this whole thing is called as a leukemia-like condition. So one of the DD for this would be a leukemoid reaction. So in this case, it looks to be a case of CML. This looks to be a case of CML, which shows a translocation of 9 with 22nd, which is a PH chromosome or BCR ABL translocation. Just remember one thing, guys. In a PH chromosome, I just want you to just recall one thing. It shows a P190, P210, and 230. I just like to add one more point, that 210 is the most commonly seen in CML, 190 is seen in ALL, and this just shows neutrophilia. PH chromosome, it basically activates the tyrosine kinase receptors, and which can lead to a case of CML. ठीक है? नहीं CML में 190 नहीं होता, 210 होता है. Okay, all of you. अच्छा, most common cause of macrocytic anemia with B12 and folic acid is actually alcoholism. Just remember one more thing. Most common cause of macrocytic anemia is alcoholism, more common than B12 or folic acid deficiencies. ठीक है? अच्छा. A patient underwent cystoscopy, and you see these are all black color deposition. These all are actually macrophages. ये ऐसे macrophage है, and in the macrophage you're looking at a black color deposition. ऐसा, इस तरह का. This type of black color deposition is called as Michaelis-Guttman bodies, and seen in Malakoplakia. It is called as Michaelis-Guttman body. It is seen in Escherichia coli. It is seen in Escherichia coli infection, and the whole thing is called as Malakoplakia. ठीक है? Okay. Next question. A 30-year-old patient was being investigated for the case of infertility, and what you see here is only, it's not a very clear image though, but What this shows actually is a case of just a Sertoli cell area. Just a Sertoli cell area. This is a better image. I'm sorry for the wrong, not a very clear image though. This is a better image. Now what you see here is only and only Sertoli cells. Sertoli cells. It doesn't show any Leydig cells. There's no Leydig cells here. Absence of Leydig cells. And hence it's a case of Sertoli cell tumor. It's a case of Sertoli cell only tumor. Clear? There's no Leydig cells and hence it's only a case of Sertoli cell tumor. These are all Sertoli cells and these are all Leydig cells. Okay, so the answer is Sertoli cell only tumor. Sure. A patient presents swelling in the front of the neck came to the clinic, complains of fatigueness, hypothyroidism and anemia are observed. So I told you, what is it? It's a macrocytic anemia because macrocytic anemia can be seen in chronic alcoholism as well as hypothyroidism. The two causes of macrocytic anemia. Megalocytic anemia is seen in B12 and folic acid deficiency. In the interstitial cystitis, will given a history of a UTI-like symptoms and there will be dysuria and burning sensation will be seen in that case. A 40-year-old patient presents with pallor and fatigueness. She's a known case of hemorrhoids. Okay, it means bleeding going on from the rectum, and therefore it shows a case of iron deficiency anemia. I think you'll all clearly see the pencil cells, and hence is a case of microcytic hypochromic anemia because of a case of iron deficiency anemia. Single nucleotide change resulting in stop codon. I don't think there is any need of any explanation here. It's a straight case of nonsense mutation. UAA, UAG, and UGA are the three examples of the nonsense mutations. This is a very simple case. I don't think I need to explain any further. Okay. What will increase the lifespan? This was a very interesting question. It was asked NEET PG 22 actually. Yes, the answer is daily decrease calorie by 30%. Okay, they'll increase the lifespan. One more thing that can increase lifespan apart from this is the take of sirtuins. Sirtuins ke baare sirtuins. What you should know about sirtuin is coded by the SIRT gene, and SIRT is of 7 types. It actually activates the telomerase activity, and telomerase activity is nothing but a case of histone deacetylase. Also remember, it also increases the insulin sensitivity, not resistance. Okay, it increases insulin sensitivity. That's a case of sirtuins. Red wine consumption will also activate the sirtuin intake. Very good. Which of the following is autosomal recessive? It is cystic fibrosis. In this, remember that about the Huntington's autosomal dominant, or achondroplasia also is autosomal dominant case. In this case, this is an autosomal recessive disease. So what NET? So NET kya hote hai basically? These are the neutrophils, and neutrophils will first get activated because of platelets. After the activation of platelet, the arginase enzyme will lyse it. Once the arginase called lysis, from this what comes out is fibrils. Because fibrils comes out, what will be captured into this is the antigen, and this enzymes coming out from this would destroy it. So just remember, it is seen with sepsis, yes. Bacterial infection, yes. Mitochondrial DNA is not at all involved here and consists of the lysosomal enzymes which can destroy the antigen. It's called as neutrophil extracellular traps. Clear hai? Chalo. Next question. Case of a hypochromic microcytic with a reduced RBC indices. I think we have discussed this already. It's a case of HbA2. So chhod dete hain. Okay. This is again a case of dragging central of the abdomen, and a purpose here shows myelocyte metamyelocytes. It is a 922 case which we discussed already. Okay. Actually, this was discussed. Sorry, there's some repetition there. A mid-aged male with painless, low-growing swelling in the neck. So what to see here is these all are the orphan anenuclei. Pause, sir. Take this one. Look at the white color areas. It's a papillary type of follicles, and what to see is a white color area cells. This all white color. दिख रहा है ये white वाला? सबको दिख रहा है बच्चों? It's all white color areas, and these all white color areas are the orphan anenuclei, and hence is a case of papillary thyroid carcinoma. देखो what question can be asked from thyroid gland? Let me लिखिए. देखो PTC है, FTC है और MTC है, right? Among this, first of all, remember follicle cells say this comes follicles, this comes from the para follicle cells. First question. Second, they can ask you about the diagnosis. It can be done by FNAC biopsy. ठीक है, this one. It cannot be diagnosed by FNAC, but yes, biopsy. You can diagnose by both FNAC and biopsy again. Why? Because this diagnosis depends on amyloid, and amyloid can be seen also in FNAC. हाँ जी, FNAC can also show you amyloid deposition. Then they can ask you about the typical mutation. See here, this shows a RET mutation, and hence the case of MEN2A and MEN2B. It's a neuroendocrine origin, and hence can be seen by neural crest cells. Just remember this PTC, it actually shows, this will show the invasion, which is very characteristic here. This shows a papilla, and along with papilla shows orphan Annie I nuclei. ठीक है, ये clear हो गया? And therefore FNAC is not diagnostic. Yes, it's diagnostic. A is the right answer here. Features of nucleus is a characteristic feature. Lymphatic invasion has to be seen, and it's excellent prognosis. Remember, follicular thyroid carcinoma, this is a typical exception here, because this goes by a hematogenous route. Even though it's a carcinoma, it takes a hematogenous route. I don't know from where have you heard granny eye, but yes, I know what orphan Annie eye nuclei. Granny eye मुझे नहीं पता, but orphan Annie is surely seen in this case. Huntington's chorea is autosomal dominant beta, not recessive. Okay. Red gene में यहाँ पर it's just a point mutation. Red gene loss is seen in a case of Hirschsprung disease. यहाँ पर it's a point mutation. You can call this a gain of function mutation. You can just call it a point mutation. That's it. Body can be seen also in papillary thyroid carcinoma. Very good. Yes, very good. Very good. Body, Samoma body can be seen also in the papillary thyroid carcinoma. 27-year-old became with road traffic accident. After 2 days, developed dyspnea and petechial rash with unconsciousness. So the moment you see a road traffic accident and then the patient has some type of issues, it has to be a case of fat and marrow embolism. Fat and marrow embolism is seen in case of fracture. Air embolism is seen in the case of Casson's disease. The same thing is called as nitrogen narcosis. The same thing is called as decompression sickness. ठीक है ना? Pulmonary thromboembolism is the most common cause of thromboembolism, and basically the origin is the femoral artery. And femoral embolism is not actually, it's called systemic embolism, not the right choice of the words. Actually, systemic thromboembolism. But remember, the most common type of embolism is a pulmonary thromboembolism. Okay. Fat versus pulmonary embolism में देखो, when you get a history of a road traffic accident or a fracture, it must be fat embolism. When you get a case of, suppose, any systemic vessels having any like DVT, suppose a case of a deep vein thrombus, DVT, and then there is embolism, it becomes a case of pulmonary thromboembolism. ठीक है? Bend is seen in a case of air embolism. Yes, bends and chokes are a case of a air embolism, and amniotic fluid embolism is seen just postpartum delivery period. You see amniotic fluid embolism is that in that case. Okay. 10-year-old male presents with edema and asarca. Diagnosis of minimal change disease was done. True. So any minimal change disease will surely respond well with corticosteroid. Light microscope will show effacement. No, it's an electron microscope finding, and hence this is the right answer. It is seen commonly with adults. No, that's also wrong. It's seen in children, and is showing obviously shows selective proteinuria. Remember, non-selective proteinuria is seen in FSGS, MGN, MPGN, and sometimes in IgN nephropathy. You can see this, but in minimal change you often see selective proteinuria. That's very, very important. Warburg effect is used by cancer cell because, so why do cells require Warburg effect? The cell requires Warburg effect only to take more, not ATP. Yes, it makes elements which require for cell metabolism. Warburg effect is seen by actually c-Myc and the tyrosine kinase mutation. They increase the Warburg effect. They can ask you, it is also called as aerobic glycolysis. It is also called as a glucose hunger. There are two names for Warburg effect that you should know there. Okay, this was seen in cervical cell tumor. It's a better image in that one. A 12-year-old male presents bloating, steatorrhea, and pain abdomen. HDQ2 is actually polymorphic. What is the treatment? This becomes a case of, yes, celiac disease, and in which the gluten is the main cause, because gluten is present in BROW, barley, rye, oat, and wheat. It shows loss of villi with cryptorchia. It becomes a case of celiac disease. So what should you avoid in celiac? It is low gluten diet. ठीक है, चलो अगला है a 40-year-old patient has arthralgia, oral ulcer, joint pain, oliguria, hematuria. इतना दे दिया यार, इतना इजी क्वेश्चन बनाते हैं नीट पीजी वाले. This is a case of SLE, and in SLE what you see is a lupus nephritis. Okay, in lupus nephritis, just remember the 6 classes, M, M, F, D, M, S. Minimal mesangial focal diffuse membranous sclerotic. Among this, diffuse is the most common, is most severe, and it shows what? Wire loop lesions. तो कम से कम फोर्थ वाला मत पूछना, मत भूलना, सॉरी. It is MMFDMS. आगे बढ़े, चलो. A raised LDH, elevated bilirubin, hemoglobinuria, and peripheral smear shows cystocytes. What is it? It's a case of microangiopathic hemolytic anemias. And you see, these are all the helmet cells. Helmet cell is also called as cystocytes. Okay. So, because it's a case of intravascular hemolysis, it will never show splenomegaly. It can be presented, it can show you, it will not show goiter also, it's a wrong actually question, but yes, it will never show splenomegaly. It will show you not HbA2, not goiter, will show you mechanical second heart because it's a case of anemia. And anemia often shows the mechanical second heart sounds. Okay, it's a case of intravascular hemolysis. Okay, now this is an interesting case. And what you see in this image are the cells in the periphery. Suppose here nesting pattern hai, in the nests. Okay, if you see at the periphery, cells are arranged like this. If you see a cells arranged like this, it becomes a case of basal cell carcinoma. Okay, so if you see this type of cells, it's called palisading pattern. Palisading pattern, it becomes a case of basal cell carcinoma. If it is a case of squamous cell cancer, will show you keratin pearls. And keratin pearls are what? It will show you pink color center assay, and around them you'll see dark hyperchromatic pleomorphic blue color cells assay. इस तरह से is what you see in a case of squamous cell carcinoma. ठीक है, palisading is a feature of basal cell carcinoma. It's a most common tumor occur in the sun exposed areas. Okay, marine melanoma, it is also seen in the sun exposure, but do remember it is the second most common. The most common tumor, if it is asked, it has to be basal cell carcinoma. Prosthetic heart valve doesn't show usually the cystocytes because prosthetic heart valve shows a macro angiopathic hemolytic anemia in which the cystocytes is very rarely seen. Okay, because of microvascular often shows the cystocytes. Okay, a middle epithelial, this we had already done. It's a case of ARDS. It's a case of amyloid. Okay, there's a vagino-cervical warts was given, and now asking you that high risk of HPV. When you have the high risk of HPV, it's both 16 and 18. Because 16 is not in the option, you have to go with 18. 16, 18, 31, 33 are the high risk human papillomavirus, and the low risk is 6 and 11. Remember, HV, it basically inhibits, has to address a protein. One is E6, one is E7. E6 inhibits the P53 gene, and E7 inhibits the retinoblastoma gene. In PNH, what RBC morphology, you will see just a typical case of the macrocyte. You can see because of hemolytic anemias, you see the reticulocytes which have more MCV. So macrocyte can be seen there. Elsewise, you don't see a specific finding as such. You can see some hemolysis, but not very characteristic finding as such. You can also see iron deficiency anemia because of prolonged hemolysis occurring through the urine. Hemoglobinuria can ultimately show iron deficiency anemia, and hence we don't teach that type of hemolytic findings in which you get macrocyte, microcyte, सब कुछ मिल सकता है उसमें. ठीक है. Achha, a 6-year-old male patient has a pain in extremities, was appeared with a history of chest infection 2 years back. HbA1c shows a high HbF and HbS. The moment you see chest infection and his pain in extremities becomes a case of sickle cell anemia. What they can ask you, the most common infection that occurs here. In a bone, it occurs due to the Salmonella typhi. That's a very important infection that occurs in sickle cell anemia. Achha. Now this is a case of a sickle cell patient. Knee pain hai, swelling hai, X-ray suggestive of a lytic lesion with sclerotic borders and radiolucent areas. A typical finding how the finding is seen in the bone. The fluid aspirate shows infections. Which infection? It should be Salmonella typhi. Because it's a case of sickle cell anemia, it has to be a case of Salmonella typhi. This completes our next part of NEET PG 2022 queries. So now you have solved around 20 questions of NEET PG 23 and 29 question of NEET PG 22. I now move to NEET PG 21 here. I hope that you all are there. I'll just take maybe 10 minutes more. Okay. यहाँ पर I just want to tell you one thing. It's a very HNPCC में you all know it shows mismatch repair gene. Remember mismatch repair gene, it is seen in HNPCC with MSH and MLH type of mutation. Okay. Secondly, it is also called as MSI, micro satellite instability. Nucleotide exchange is seen in xeroderma pigmentosa, but xeroderma pigmentosa, as you know, it actually progresses to the squamous cell cancer and basal cell carcinoma. Okay. Then comes the homologous repair. Remember, homologous repair is very, very important and was also asked multiple times in groups also. That homologous repair is seen in answer is Bloom syndrome, ataxia telangiectasia. It can be seen also in Fanconi's anemia. So how to remember this homologous mutation? Remember this as A, ataxia telangiectasia, B, Bloom's syndrome, and C is the C of Fanconi's anemia. Fanconi's anemia. So A, B, C, they all show the non-homologous nature. It's actually the A, B, and C. Just 1 second, please. A, B, and C, they all show the homologous end joining repair mutation. It's not non-homologous. It's all homologous. Non-homologous nahi hota. These all are homologous, not non-homologous. Please remember. These all are homologous, not non-homologous. Clear hai? In the homologous recombination defect, it is 3 of them. A, B, C. Non-homologous nahi hota. It's all homologous. I'm very clear telling you. ठीक है? हाँ, नॉन होमोलॉगस स्किड, पर ट्यूमर नहीं है ना बच्चे, मैं ट्यूमर की बात कर रहा हूँ. इट्स अ ट्यूमर. नॉन होमोलॉगस कैन बी स्किड बट दैट्स नॉट द ट्यूमर एक्चुअली. ठीक है, ऑल ऑफ यू ओके विद द क्वेश्चन? क्लियर हो रहा है ना? Homologous end joining repair mutation is seen with A, B, C, ataxia telangiectasia, Bloom syndrome, and Fanconi's anemia. All just give me a thumbs up here. Let's move on. I just want to move ahead out of this. ठीक है? अच्छा, a 30-year-old patient presents with fertility for 1 year. Evaluation shows mild anemia, mastomegaly, TLC of 1,50,000, and there's neutrophil, eosinophil, all of them, which points towards a case of ME ratio of 18:1, and it becomes a case of CML, chronic myeloid leukemia. And hence, what should be done? What you should do is, for CML, no need of PET's imaging, right? No need of immunotyping. Labs can be done, but if you have an option of FISH with PCR, that's the best thing to do. PCR क्या दिखाएगा? Will show you the PH chromosome of the P190, 210, and 210. If you have this as the answer, it's more sensitive, more specific, and the best answer here. भाई सब होमोलोगस है, नॉन होमोलोगस नहीं है, होमोलोगस है. आई जस्ट सेंड यू द रॉबिन स्क्रीनशॉट ऑन द ग्रुप, तो क्लियर हो जाएगा. ठीक है, सब होमोलोगस है. अ पेशेंट प्रेजेंट्स विद द वेब नेक, शील्ड, नेस्ट एंड शॉर्ट स्टेचर. क्या हो गया? इज टर्नर सिंड्रोम. टर्नर सिंड्रोम इज रिमेंबर्ड बाय अ निमोनिक ऑफ, यस, it is remote clown, CLOWNS. Then C is cardiac anomaly, L is the lymphedema. ठीक है, O is ovaries are not well developed, webbed neck है, normal intelligence है, and S से 3 चीज है, shield shaped chest, short fourth metacarpal, and short stature. Remember, the cardiac anomaly most common is bicuspid aortic bone, Turner syndrome. Okay. Fourth, a research scholar was working on a cytoskeleton of a chronic alcoholic patient, and what they show is the several strands of a fibrous protein that bound together as a stable structure and distributed tensile force across the cells. What do you call these cells? Intermediate filaments. Okay. However, now the question is, it shows a hepatocytes with the reddish inclusion bodies. So what are these? It's a cytokeratin. It's a case of cytokeratin, and such structures are called as what? It is called as Mallory hyaline or Mallory Denk bodies. Such bodies are stained by cytokeratin 8 and 18 to be more precise, but because they're case of intermediate filaments, it becomes a case of A. It becomes a case of A. ये B नहीं है. ठीक है, आंसर तो क्या है? A है. अच्छा. A patient with generalized fatigueness, tiredness, primary clinical examination is uneventful, normal TLC है, DLC है, no immature cells are seen, but now the patient has a effaced architecture, intended nucleus, prominent nuclei is having a atypical cells. ठीक है, 10 पॉजिटिव है, बी सेल 2 पॉजिटिव है. अब बताओ क्या होगा? बड़ा सिंपल है. देखो, जब मैंने कहता डबल एल, ये होगा बी सेल 2 पॉजिटिविटी, साथ में 10 पॉजिटिव. बर्किट में सीमिक पॉजिटिविटी. नॉन हॉस्किन इज अ वेरी ऑब्वियस, नॉट वेरी क्लियर टर्म. Mycosis fungoidosis is also called as Sézary syndrome, and this becomes a case of cutaneous T-cell lymphoma. Cutaneous T-cell lymphoma. Okay, so the answer is, बोलो क्या होगा? A, follicular lymphoma. चलो, a patient has a mediastinal mass, was diagnosed with red cell aplasia. ये क्वेश्चन बहुत इंपॉर्टेंट है. It should point towards a case of thymoma. Thymoma really shows what? It shows PRCA, pure red cell aplasia दिखता है thymoma में. The answer is C. अच्छा, pap smear with a hyperchromatic nuclei, pleomorphism with low maturation index and complete epithelial lining, but not involving basic membrane. क्या हो गया ये? It's a case of cervical interval neoplasms, 3, also called as HSIL. It's a case of carcinoma in C2, and hence it's a case of dysplasia. And which dysplasia? Severe dysplasia without any involvement of the base membrane. ठीक है, चलो. Now 34-year-old patient presents with fever and migratory polyarthritis of lower large joints and tachycardia. Murmur is pansystolic. क्या बनाइए? Rheumatic heart disease. ये है बेटा rheumatic. This whole thing is rheumatic heart disease. It's a ash of bodies, है ना? And ash of body is seen in what disease? बताओ. It's seen in rheumatic heart disease. So when you get this type of inflammatory cells inside a myocardium, it talks about a rheumatic heart disease. Okay, rheumatic heart disease. Poor prognostic marker for multiple myeloma is a case of beta 2 microglobulin. It can be measured both in serum and can be measured also in the urine. Serum and urine, both of them, it can be measured there. Remember, multiple myeloma, the basic marker are CD38 and CD138. They show a finding of crack where C is hypercalcemia, R is renal failure, A is anemia, and B is bony lesions. They've asked you what type of amyloid it shows. It shows a primary AL amyloid. Primary AL amyloid. हाँ, caterpillar like cell इसमें जो दिखता है, जिसमें it shows a cell like this. It's a macrophage with this type of nucleus. It is called as anastomoses. It's an anastomoses. Clear हुआ? चलो. Now we move to question 10. 10 क्या कह रहा है? A patient is a male present with gum bleeding and easy visibility fever for last 2 months. Generalized examination finding were non-specific except segment pallor and petechial hemorrhages all over the body were seen. Hemoglobin is 3. TLC is hemoglobin low है. TLC is also low there, and the platelet count is also low. Okay. Macrocytes are seen with creatinine count is very low. Low है ना? Fatty streak, जैसे वर्ड लिखा, ये देखा ना, ये वाला वर्ड fatty streak मतलब क्या? देखो, when you say a ratio of a cell in the bone marrow is 1:1, what you mean basically is the percentage of cells is to the fat is 1:1. As the age increases, fat would increase and cell will decrease. So what has happened in this case is the patient now has a pancytopenia, and along with that the patient has an increase in fat cells in the bone marrow. Fat cell in bone marrow मतलब decrease in cells. Decrease celerity मतलब hypocelerity. Hypocelerity मतलब the whole case has become what? Aplastic anemia. It has now become a case of idiopathic case of aplastic anemia. So what gave me a hint? The hint was this word, guys. क्या word था? Fatty streak. Absent megarocytes. No immature cells. It points towards a case of aplastic anemia. Idiopathic case of aplastic anemia. Let's now move to NEET PG 2020. Okay. The last segment of my questions is NEET PG 2020. All of you ready, guys? Sub ready ho? नहीं, they can be hepatomegaly, they not be splenomegaly in aplastic anemia. Splenomegaly नहीं दिखना चाहिए, hepatomegaly के same. In parvovirus, petechial rash are not seen. It's a case of a macular papular rash. It is called a slap cheek appearance. Okay, slap cheek appearance. अच्छा, hepatitis में which is the most common cause in aplastic anemia? In aplastic anemia, it is basically the HBV, HCV, HIV, and non-A, non-B, non-C. It's called as G is also one of the cause. Okay, but for you, I would say HV is a better answer there. Why not myelodysplastic? Because myelodysplastic shown what? Why not this one? Because it should have shown pancytopenia with a cellular bone marrow. Okay, and hence it cannot be answer D. Clear हुआ? ARTRA. ARTRA is used for treatment of what one? बोलो, हमने पढ़ा ना? ARTRA and arsenic trioxide is used for PML RARA. It's a case of APML in M3. ठीक है? अच्छा. A 30-year-old woman came with complaints of easy fatiguity, exertion and dyspnea, weight loss. The patient has frequent falls and she was given folate. Her anemia improved, but neurological symptom worsened. ऐसा क्यों होगा? Because she was given only folic acid alone. So when you give folic acid alone, what happens? All the B12 which should go towards making the methyl valine coenzyme A, देखो succinyl coenzyme A, it should go towards methyl valine coenzyme A, and this requires B12. On the other side, यहाँ पर है homocysteine which converts to methionine in presence of folic acid and B12. If I give folic acid alone, तो क्या होगा? B12 will shift from this reaction to this reaction, and so most of them will start making methionine. When they make methionine, they ultimately make tetrahydrofolate, and tetrahydrofolate will ultimately become, it will make what? The DNA, and DNA will improve the anemia. However, this is not being made, and because this one decreases, it will cause worsening of neurological symptoms will worsen. So क्या है इसका आंसर? Folate therapy has rapidly used the B12 and has shifted the reaction of B12 from this one to this one. And because the whole thing has decreased tetrahydrofolate, and therefore what has happened? It has caused the improvement in DNA. However, neurological symptoms have worsened. Answer is D. A 25-year-old patient presents with routine physical examination. Tall hai. Extremity was found to have early diastolic murmur. Points towards what? Yes, AR. Aortic regurgitation. What is the most probable mode of entrance? It's organ dominant. Is what? Is Marfan syndrome. Marfan's का mnemonic भी Marfan है. Okay. What is Marfan syndrome? याद रखना. Mitral valve prolapse, aortic aneurysm, retinal detachment, fibrillin deficiency, arachnodactyly, negative nitroprusside test, and skeletal changes, which is the basic finding of that. It's a A. The following factors play a major role in initiation of thrombus formation. सबसे important thrombus formation in the triad of Wiskott. Wiskott said three things. One is endothelial injury. Then he told what? It is hypercoagulability of blood. And he said second one, two. And third he said abnormal blood flow, which often is a case of stasis, or it can be a case of turbulence. Stasis is more common than turbulence. Here the answer is endothelial injury. That's the best answer here. Okay. A 33-year-old patient presents with 5-week history of calf pain, swelling with low-grade fever. Serum levels of CK is elevated. Okay. Muscle biopsy reveals numerous eosinophils. कहाँ जा रहा है ये बताओ? Peripheral blood eosinophilia is seen. The following interleukin is responsible for this. This question is about eosinophilia. देखो what happens? T helper 2 cells secretes interleukin 4, 5 and 13. 4 activates B cells to release IgE. 5 increases eosinophils. 13 increases mucin production. Question क्या पूछ रहा है? Responsible for eosinophils. कौन सा होगा? IL-5. IL-5 is not in the option. Then you must see that who will stimulate IL-TH2. Actually, IL-4 is the one which stimulates TH2. Because IL-5 is not in the option, I would choose IL-4. However, if the answer would have been having IL-5 is a better answer than IL-4, because IL-5 is not in the option, I'll now choose IL-4. अब clear हुआ? चलो. Remember, IL-2 will activate CD8 T cells. IL-1 will cause fever and will also activate the neutrophils. Will activate neutrophils, and IL-6 activates the plasma cells. It also increases the acute phase reactants. चलो. This is a typical case of I don't think there's anything to discuss. देखिए समझ आता है. It's a case of Barrett's esophagus, right? Many times you have seen this question. It's a Barrett esophagus. It's a case of metaplasia. Okay, this is a very interesting question. A 5-year-old male patient presents in the clinic with a history of recurrent infections On examination, the child has rashes. Routine blood investigation revealed a patient had low platelet. What is this question talking about? First, I got infections, I got rashes, and I got thrombocytopenia. Thrombocytopenia, eczema, infection. The whole thing is called as Wiskott-Aldrich syndrome. Job syndrome is job has a good fate. FATE. Matlab facial anomaly. It can be abscess, which is cold abscess. It can be teeth, which is abnormal, and eczema with increased amount of IgE. It's a job syndrome. Henoch-Shan-Purpura, HSP. It will show you triad of what? Will show you a triad of glomerulonephritis, arthritis, will show you colic, pain, abdomen, and will show you the palpable purpura with increase in the thrombocytes, will show you thrombocytosis. Okay, Bruton's X-linked A globulin will show you all decreased amount of antibodies. All antibodies absent because of BTK mutation. It's a X-linked recessive disease. बस ये हो गया. Okay, cold abscess and job syndrome लिखा तो मैंने cold abscess है ना, cold abscess and job syndrome. ठीक है, चलो. The following is a correct statement for a Huntington disease. Correct statement पूछ रहा है. It is showing you a try what repeats. Yes, very true. And what is that? CAG. Okay, not COG. Loss of function नहीं होता, gain of function mutation होता है इसमें. Gain of function mutation happens, and chromosome number 4 is the main thing involved in this case. Chromosome 4 is the main case involved in this case. ठीक है. Okay, in this case, I just repeat all the gain of function mutation, gain of function, and the loss of function. Okay, anything which is occurring in the coding region is gain of function. Anything in the non-coding region is a loss of function. The coding region में Huntington disease, which is a CAG. If you see about Friedrich's ataxia is a gait issue. So GAA याद है ना, GAIT, gate से GAA याद हो जाएगा. Myotonia dystrophica, it is basically the CTG repeats, and fragile X syndrome में CGG repeats. These three are, yes, loss of function, and that one is a gain of function mutation. Gain of function mutation. Gain of function mutation. Clear हुआ? चलो. A 10-year-old boy presents with complaints of fatigueness, abdominal pain after playing football. Now, this is a typical case where the patient has a painful swelling in the digits of the pars and was having small spleen. यहाँ पर क्या हो गया होगा? It might have got, yes, autosplectomy. This whole thing is talking about which part? बताओ. The whole thing talks about which part? Yes, it's a case of sickle cell anemia. बिल्कुल सही, very good. It's a case of sickle cell anemia. ठीक है? Okay. A 25-year-old male patient presents with 2 centimeter thyroid nodules for which a thyroidectomy was done. And what you see in this part is a round white areas. है ना? बिल्कुल round white areas है. The round white areas here are what? It's a orphan Annie I nuclei. Just remember, it can be showing like this also. It's called pseudo inclusion, but sometimes it can also show you a nuclear grooving. दोनों दिख सकते हैं, and both of them can be appreciated on FNAC, and hence it becomes a case of papillary thyroid carcinoma. A 10-year-old came with complaints of thyroid swelling. This we have already seen. TSH is elevated. Post-operative HPE report shows a lymphocyte infiltration, a Hurthal cell. The moment you get a case of Hurthal cell, what is it? It becomes a case of, yes, Hashimoto thyroiditis. Hashimoto thyroiditis. Loss of food process, it's yes, we have discussed it already, minimal case disease. A 51-year-old patient presents with a clinic with hematuria to the clinic. On examination was found to have normotensive with pateledema, 51%. The patient has glycosuria and has creatinine level of 9. What is it? It becomes a case of RPGN. The following one should do to identify the etiology of the disease. This patient has a hematuria. There's normotensive with pateledema. Okay. Investigation revealed a patient has glycosuria, non-glycosuria, does not have glycosuria, does not have glycosuria, and creatinine level has gone to 9. So this gives a case of RPGN. Among the things that is given, will help to diagnose RPGN is the first one. It causes RPGN type 1. It will become a case of RPGN type 1. It's a good Pasha syndrome. Good Pasha syndrome. Sure. The following will have irregular, bulky, friable cardiac vegetation. The moment you see bulky, the answer is infective endocarditis. Limb sac में क्या मिलेगा? It's a verrucous. ये क्या है बेटा? Verrucous. Verrucous on both sides. It's in both sides. In rheumatic, you see a friable. Okay, less friable, but this is maximum friable. This is a maximum friable vegetation. Is seen along lines of closure. Along the lines of closure. The answer is B. The following is in cardiac biopsy to patient who has a MI perfusion injury. The moment you get a re-perfusion injury, it means the blood has moved back to the area. With blood, what goes is reactive oxygen species, and hence it shows the oxidative damage is the most common cause of that injury. Along with that, what happens, because RBC moves in that area, RBC causes what? RBC causes hemorrhagic myocardium. Two things are seen. One is because of contraction, calcium. It causes contraction. Because of RBCs, it shows hemorrhage. And because of the reactive oxygen species, it causes oxidative damage. The whole thing is a finding of re-perfusion injury. The answer is B. A 20-year-old presents with a swelling in the wrist and has Verroque bodies. I don't think I need to explain anything. The answer is clear. It's a case of schwannoma. This is a case of a heterosexual patient, and look at the small things here. In a case of chronic watery diarrhea, it becomes a case of cryptosporidium. Had them with giardia, I'll show you trophocytes. And trophocyte of giardia, how to identify? It's a pear-shaped cell assay, and has these type of with the nucleus assay. This type of trophocytes are seen in giardia case. Isospora, it shows a oval-shaped structure, and CMV often shows a owl eye inclusion assay. It shows a nucleus like this, and the nucleus will have a halo around it. Yes. This type of halo is seen in CMV, cytomegalovirus. Here the answer is cryptosporidium. Okay. A kid presents with history of blood in stools, polypoid mass in the rectum. These all are the glands, large glands with mucin. Large gland with mucin is a case of juvenile polyp, simple case of juvenile polyp. A 30-year-old male complains with a swelling around the knee joint, and there is a many giant cells with motor cells. Giant cell is what? Giant cell tumor. Giant cell tumor is called osteoclastoma. It's a giant cell tumor. Okay, giant cell tumor. Having sarcoma, I'll show you small, round, blue cells. If you see malignant chondrocytes, it is chondrosarcoma. If you see malignant osteocytes, it becomes a case of osteosarcoma. Chalo. The following is true about PAN. PAN involves medium-sized vessels. ANCA is negative in PAN. 30% may be HS positive, and they have hypergammaglobulinemia. So answer is clearly C. Clearly it's C. 21. This is a typical translocation of 12 with 16. This is a factual question. I don't want you to go more in depth of it. 12-16 translocation is in the case of myxoid liposarcoma. Typical case of myxoid liposarcoma. Okay. Next is a 20-year-old patient presents with a clinic with a history of malabsorption, diarrhea, and poor appetite, vomiting, and the patient has strep hyperplasia villus atrophy. These two lines, these are two lines here. It points towards what? It points towards a case of celiac disease. Vipers में क्या मिलेगा? In vipers you get PAS positive macrophages in the lamina propria layer. The patient has a mucin filling stroma in the breast. Okay, so when you get a breast में mucin fillings in the stroma, it becomes a case of colloid carcinoma. Okay, colloid carcinoma shows what? Mucin in the breast mass. In the breast mass, क्या दिखता है? Colloid carcinoma. ध्यान रखना. The moment you see a colloid filling a breast tissue, it becomes a case of colloid carcinomas. अच्छा. A 35-year-old woman has a long history of dyspnea, chronic cough, sputum production, wheezing lies in the respiratory failure, and bout of pneumonia. The patient is non-smoker or alcoholic, but the patient is not a smoker. ध्यान रखना. Now the patient has this type of dilated bronchioles, and that too at the upper portion. Even though the upper portion is commonly involved in smoking, this becomes a case of what? It becomes a case of emphysema. Because it's a case of emphysema, and the patient, you're non-smoker, you have no other way but to choose what? Alpha-1 antitrypsin deficiency. The first option shows Cartagena syndrome, which will be seen in a case of bronchiectasis. Even such fibrosis will show bronchiectasis. This shows the good Pasha syndrome. The answer is C. The answer is C. A patient has a history of fatigueness, tiredness, on investigations to have hemoglobin of 9, MC of 101, as macrocytic RBCs. What is it? I told you the most common cause of any macrocytic anemia is chronic alcoholism. Just remember this case. Very typical case. Okay, till now, I don't think there's any doubt. I have been trying to solve all the questions till NEET PG 2020. This is the last one. It's a typical case of finding. This is not a case of bronchiectasis because I'll show you a large bronchus when dilated and destroyed. I will on the lower lobes. So in the case of bronchiectasis, you get a history of fever with chills and rigor. They involve lower lobes, not the upper lobe. That's the first thing. You should get a history of fever with chills and rigor. Second thing. And you should not see the involvement of bronchioles. You see the involvement of bronchus in a case of bronchiectasis. Hence, the answer is not bronchiectasis. The answer has to be the emphysema, and it's a case of alpha-1 antitrypsin deficiencies. So, guys, any doubt from this part? We have been able to discuss all the questions from NEET PG 2023, 22, 21, and also 20. I promised you I'll discuss the 4 years of NEET PG questions. And I think I will be able to. Achha, tomorrow is Dr. Ashwini's lecture, and he will also take a 1 hour of power pack session. If I just request, sir, because we had to do recording, sir also is here, and if he's listening to me, I can come to just motivate to you and just let you know how to just interact and how will he do the session, and maybe if sir is there and listening to me right now. Just believe on these questions covered in this 1 hour session. Sir will also cover his anatomy questions right from 23 to 2020 and would be trying to cover all these questions just 1 hour, just like me. And here comes our sir, and he would just be telling you how to.
No. My day is day after tomorrow. First of all, it's not tomorrow. So tomorrow is after J, I think.
Because
I got a slot day after. Oh, sorry.
सर अभी स्टूडेंट्स को हम क्या बोले, कैसे आगे बढ़ना, इसको फुल कर सकते हो?
नहीं, that's okay. Yes. Today anatomy pathology combined session will take. Yes. So my session is day after tomorrow. Actually, tomorrow Dr. Jay is taking, I think.
Jay sir, I don't. Maybe Jay sir ले रहे हैं, मतलब.
He'll also be meeting us within like next 15 minutes, so he'll tell us. So yeah, we will be taking this session. I hope that you liked the revision video which I posted, and yes, sir, he's always proactive on the YouTube and everywhere. Yes.
We should not take more of time, but just to talk about what you do right now. Depend upon your notes only. Don't take anything new right now. What you've read is read. Don't take any new things. Try to just watch these sessions that you are coming across. The sessions of
who's calling?
Dr. Ashwini, Dr. Jay, all of them should be there.
I should pass his number to everyone.
Dr. Jay is already.
Sir, people are listening to you live right now. कल आपका सेशन है क्योंकि I just talked to him.
तो अब जो है आपको बस इसके ऊपर डिपेंड करना है एंड डोंट टेक एनीथिंग न्यू देयर. Believe me, guys, you all have studied much and better. What you can just, I will just request you one thing. One, the session is over. Just to motivate all others also, and just try to put your comments when this video is over, because we will not be able to see the live comments when the video is over. Just put a like, and if whatever comes to your mind, I tried my best to cover all the things, even though I'm not very well. But I just thought of taking this session was very important for all of you. So spending quite long, and so we just decided to put upon the session. Same thing with Dr. Jay will do tomorrow. Let's take a 1 hour session, not more than that. Ashwin sir will take the day after tomorrow. We'll ensure that your preparation is the best coming up in the NEET PG 2024 there. So guys, don't worry about this a lot. I just one request from all of you, just 480 students are seeing this live, and just one comment from your side, just to motivate me and to all our efforts. How do you like the lecture? And this will move ahead from this. Take care. God bless you all. About how to prepare and what to do, I just posted a different video. It's not right time to show that. Go back to your main lectures, read those things. Do not take anything new. Read the topics again and again, and just don't waste time going ahead right now. With this, take care. God bless you all, and best wishes going ahead. Do not forget to put a comment once the video is over and live stream is ended. Once this video is over, okay, just come back after say 10 minutes and put a comment there. It really motivates all of us who are trying so hard to motivate all of you. Okay, take care. God bless you all. Bye.